the big red flag that I would like to come out of any message going through with digital is that, yes, it works. It works, of course, across a load of different platforms, but complexity and digital needs particular scrutiny. Individuals with comorbidities, who are the individuals who are generally, the inverse care law applies to them. Those individuals rolling out digital uniformly across a practice or a network setting, saying this is the default method of communication. That is, I think, a dangerous assertion. Yes, in certain parts of the country where digital is mainstream and Westminster bubble and so on, of course, there are huge advantages. But we need to be mindful that complexity, which is a minority presentation in the country, most practices don't deal with high-level complexity. They deal with moderate level, but the practices which do, the practices in the high IMD groups, deprivation groups, rolling out digital and saying you must exclusively use this, or this is the default model, is in itself a step back in terms of safety as well as communication.
Hello and welcome. My name is Sarah Rybczynska-Bunt and I'm a Research Fellow in the Community and Primary Care Research Group at Plymouth University. You are listening to the second podcast in this series that is asking what the pandemic has taught us about the impact of a remote primary care service on patients with complex health and social care needs. In this podcast, I'm joined by 3 clinicians from 3 different primary care practices. These 3 GPs are involved in the Deep End Group in Plymouth. That is, a network of GP practices who work in the most deprived communities and face similar patient groups, including those with multimorbidity, drugs and alcohol problems. In this second podcast, I will be asking them to discuss potential solutions and recommendations to improve the way we remotely triage and consult based on the findings from the Remote by Default study led by Trisha Greenhalgh. I'm joined once again by Dr. Daniel Korn from Pathfields Medical Group in Plymouth, Dr. Carmel Boyan-Irving from North Road West Surgery in Plymouth, and Dr. Pia Martinez from Adelaide Street Surgery in Plymouth. Welcome and thank you so much for taking the time out to join me once again. So I wanted to have a discussion around when to offer face-to-face, when to offer a phone appointment and when to offer a video consultation, and whether standardised procedures for deciding that are going to be helpful. And for a while it looked like that remote consulting was here to stay, and now we know that the pendulum has now swung again and that there's more pressure to ensure more face-to-face appointments are offered. So getting your thoughts on that would be great. And I'm wondering whether standardised procedures are helpful to decide what type of appointment to offer. So clinicians told our researchers that telephone calls and texts were really efficient ways to manage minor ailments. But there was also that concern that for some people, there was a lack of indicators from the patient to work out what sort of appointment type was needed. And do you think this is something that individual clinicians get better at working out over time, or are standardised procedures helpful? So I'll go to you first, Dr. Pia Martinez.
So I had a little bit of a think about this, and I don't think that there is a really easy way of kind of jumping to any conclusions about that, is my feeling. I think we just need to take every single case on its own merits. I think we need to try and get as much information as possible from different workers. I think that's a helpful thing to do. And what guides me is maybe the person's harbour worker or the person's housing support worker might input to me as to what the best mode of consultation might be. Where I work, so I'm thinking particularly of when I'm working at the hostel, because that's more concentrated in complex patients. I'm thinking that maybe I underestimate, in a way, my patients' willingness and convenience to actually speak to them remotely. Although, because the strange thing is I'm in the building, I'm going there, I'm doing outreach clinic, but actually some of them might prefer for me to ring them, even though we're in the same building. So what I'm basing that on is when I first went back to the hostel, having spent a year just on the phone, that we were encouraging patients to say whether they felt they needed face-to-face or telephone. And some were happy with telephone, very few, maybe just 1 or 2. but I would phone them up and have a decent consultation. I'm not offering that option anymore. I've gone back to how it was before, which is I roll up, they've put their names down on the list, I try and get hold of them and call them into the room. So part of what it is for me is I have quite a big DNA rate with these people. You know, some days I see everyone who's on the list. A lot of the time I see maybe half of them. Some of them have just wandered off, not remembering that they put themselves down for an appointment. Some have put themselves down for an appointment, changed their minds. You know, the housing support worker will go and find them and they'll say, oh, no, I don't want to see the doctor anymore. So I'm just wondering that actually maybe I should try phoning people more, either asking them for their preference initially, or if they don't turn up, try and ring them, which I don't tend to do. So some of my patients never seem to answer the phone, but they have presumably agreed to a phone call. And it actually made me question, I'm actually a little bit unsure of the process for them to be put on the list. I'm assuming that either the patient or a support worker rings the surgery and gets put on my list to ring them. I think that's how it is. But I'm not entirely sure, so I'm going to look that up. And I'm imagining that there is usually an issue with credit, or that patients, the patients I'm talking to are often people who are on methadone, opiate substitution, or they're alcoholics. Some of the time they've gone out by the time it's time for me to ring them, and they've had a few cans, or they've had a bag of heroin, and they're not really in a fit state to talk to me anymore. And I know that sometimes the patients are actually not in the right physical place to talk to me anymore. We assume, us middle class people, that you're sitting in your house when the phone goes off and you've got complete privacy to answer that call. But if you're a rough sleeper, you know, you could be outside Aldi and maybe you don't want to talk about your mental health problems sitting outside Aldi, or with a load of people around you that you don't feel safe with. And then, you know, as I mentioned last time, you know, quite a lot of the time patients have also changed phone, and that number you're ringing them on is no longer valid.
Yeah, and that's really interesting. And to think about that, if you don't reach somebody on the phone, the range of factors that could be of why they don't pick up the phone there and then. It's not because they've forgotten about it, but maybe they're just not in a space where they can actually receive that phone call. So yeah, so that's really, really interesting. Thank you, Pia. And Dr. Daniel Korn, what about you? Do you think standardised procedures are going to be helpful in this sort of scenario of trying to identify what appointment type, or what are your thoughts about trying to identify what a patient needs?
I agree with Pia's opening statement that I feel like it feels just way too complex to try and have sort of one standardized approach, because each patient is different. And we've actually got so many different modalities of engaging with them now, telephone, text, email, that to actually kind of try and create some standardized procedure. And I think what patients are really asking for is us to listen to them and what they want. So I don't know how we can deliver that by some sort of one size fits all or approach or kind of protocol. I think in the ideal situation, we've got all these modalities, and if we had infinite capacity, we would say, what do you prefer? Because patients do prefer different things. There are busier people who prefer to do stuff by text. There are people that prefer telephones, and there's some people that just can't handle any of that and need to be seen. So the question about whether they do actually need to be seen is where there's sort of maybe a bit of, I suppose, a bit of potential conflict can come up, because from a medical perspective, certainly over the last 2 years, we've become more confident at managing things remotely and identifying what we do feel doesn't need to be seen. But if you're in the midst of that conversation with the patient where you're like getting into this ground where I'm like, oh, I don't think it does need to be seen, but the patient wants to be seen, ultimately, you know, you're not actually really going to make lots of progress if you're in that conflict. So being able to offer an appointment, irrespective of whether it's really needed or not, to kind of make a diagnosis is kind of maybe a bit irrelevant, because actually you're probably not going to maintain a good rapport and progress. We are currently transitioning to trialling a new model at the moment to give receptionists are going to be offering some of our routine slots each morning. They're going to be offering patients the option of a face-to-face or a telephone call, and letting patients have some choice over whether they think that is needed or not. because it feels like that's what people are asking for. And there is an issue around doing a telephone call to establish after 5 minutes of history that someone does need to be seen. And then, you know, if it's not always that same clinician that will be seeing that patient. And it's fairly difficult, much as you've already got the history, to just purely rely on a colleague's history. You will inevitably end up in that next consultation revisiting some of that history. So are you duplicating work there? I think there is a question over that, and we're trying to kind of have a look at some of our data to see how many of our telephone consultations do inevitably end up in a face-to-face, and are we just kind of you know, delaying the inevitable or duplicating work? So I think there is a question around that.
Yeah, thank you for that. And that's really helpful, just to kind of think about, in what ways does it you end up kind of duplicating what you're already needing to do. And if there was to be some guidance in and around trying to understand complexity and complex need, and how to offer a particular appointment types, or to, you know, as guidance of how to decide those things, what sort of information do you think it should include? So standardized procedures are obviously we're not in favor of here, but just in terms of like guidance, you've said about preferences, but is there anything else that, you know, would be helpful for people to know and people to understand when kind of making these decisions?
I was trying to think about this question, and I was struggling with it a bit, because I'm not sure that I could think of anything other than going with the patient preference. And we can actually put markers on notes: prefers to be seen face to face, prefers a telephone call, prefers consulting remotely initially. But it's just going to be so dependent on the issue at hand. Sometimes it is really quite simply a medication issue, that something wasn't collected or issued correctly. That can be done very quickly in between other things, but sometimes it's a more complex issue to discuss. So it really depends what the patient's presenting with. So in terms of whether I can think of something to advise other clinicians, you know, I was trying to think of the various complex the patients. I'm running a list this morning that is for our most complex patients with functional illness and chronic pain. And there's a mix of patients that prefer telephone, face-to-face, and I've got one patient that really only likes to interact by text messaging, which isn't actually the most efficient way to do things. And I think that, but that's their preferred method. So I'm kind of responding to their needs once you get to know them, or we've sort of established a connection. So I'm afraid I don't know if I've got a clean answer to that one.
So really, almost like getting to know your patients is the thing that's really quite helpful, and taking an interest in their preferences. Absolutely.
And I think patients have, you know, had to do a lot of adapting in the last 24 months about how, you know, trusting in the process, because I think, you know, they've been used to seeing someone face to face, and there is inevitably a reassurance about just having someone look at you, or, you know, us being a tonic by our pure presence or the things that we say, or building up that rapport. And I think patients have had to adjust to being reassured by remotely, by telephone, these other means. And for some patients, as you were just saying, if you get to know them, you kind of understand which of those methods kind of suits them and that they will respond to, and go with that. But from the offset to say, is there a bit of advice or approach that you could take to with a patient with complex needs? I just can't think of it before understanding them a bit better and knowing what it is that they need and how they kind of work.
I think you've said quite a lot just in terms of saying about the continuity of care and how important that seems to be in helping you decide those things. So guidance in and around actually, you know, having different people at different times, not taking account of preferences. These are all the things to avoid when working with these sort of groups. We're now joined by Dr. Carmel Boyan-Irvin. So thank you for joining us. And we're moving on to our second question, thinking about quality clinical care and what that means for complex patient groups as well. So one of the things that clinicians told our researchers is that they often had to support some patients with complex health and social care needs to think at a consultation in order to get a really coherent understanding of the problem, and sometimes they need to spend a bit of a longer time doing that. And if patients appear distracted, the remote consultation would be ceased and rearranged for an in-person appointment or a telephone appointment at another time. So my question is, how would you advise a clinician who has experience of remote consulting but less experience working with patients with complex health and social care needs? And are there additional things to be aware of in a remote consultation? So I'll go to you first, Dr. Carmel Boyan-Irvine.
Yeah, I think somebody who's got experience with remote consulting but less experience with complexity, I think I can't speak for those clinicians at the moment, because all of our clinicians in our health facility have experience of complexity. And with complexity, as you know, we find that remote consulting is less effective because of the higher risk presentations, and also because of some of the communication issues that can arise with remote consulting. So a lot of the individuals with complexity are individuals with severe mental illness, learning difficulties, literacy problems, or just people who cannot afford a smartphone or cannot use it. And those individuals tend to be a lot of them tend to be grouped in the lower socioeconomic deciles anyway. And so those individuals, we tend to have a default to want to not consult remotely, but to want to consult face-to-face or by telephone. So our first default would be not to remotely consult with them, to consult by telephone or face-to-face. If their preferred option was remote consulting and there were difficulties and they became distracted or whatever, we would want to understand what was causing that. Was that a communication issue, or was that something to do with their pre-morbid presentation, perhaps one mental health presentation? And we would probably want to communicate with them very quickly, again, either face-to-face or by telephone, to rectify that.
Same question to you, Dr. Pia Martinez.
So there's a couple of things I want to emphasize at the beginning, which is one of them is on the back of what Daniel was saying, is I really feel that one size fits all can be derogatory. So, and I think people who don't have experience with complex patients can often come across as quite derogatory to these patients, and my patients will tell me that. And I think what's really key here is actually simple thing, which is time, which, you know, we don't have a lot of, but just somehow, even if you're not giving the patient more objective time, to somehow imagine that you are, to somehow imagine that you're not in a hurry. Because as doctors and clinicians, we can often kind of have that feeling of speed about us, and the patients will pick up on that. And in my experience, they'll often interpret that as us thinking they're not important. And that really doesn't bode well for a consultation. And I think that's probably one of the things that quite often could happen if you weren't experienced, or that if you were a bit fearful, maybe even, of this consultation. I think we need to be unhurried, we need to be non-judgmental, we need to be kind and considerate. And I think one thing that might help people that don't have experience of this is to actually think about this consultation and this patient, just make a kind of analogy that this is just another patient that takes time, but that we're happy to give that time, as opposed to a patient that takes time and we're not happy to give that time. Make the parallel, for example, with something like a palliative care patient or a complex diabetic, rather than thinking of them as a drug addict or an alcoholic or somebody with annoying mental health problems. In terms of trying to decide what kind of consultation you need, or whether to stop the consultation, which you mentioned, I think, you know, as you become more experienced with working with these people, from my own experience, I've become more comfortable in actually continuing the consultation under circumstances that maybe other people would not. So before taking on the job I'm in at the moment, I wouldn't consider speaking to somebody who was intoxicated. If that was the case now, I would probably never speak to most of my patients, because they're always at least a little bit intoxicated, most of them. But I draw the line somewhere. I wouldn't want to continue a consultation with someone who seemed out and out drunk, or who was almost comatose. I mean, a lot of my patients are clearly under the influence of benzos and are kind of falling asleep quite readily during the consultation. And those consultations are not massively helpful. And I probably wouldn't cover very much in that consultation and would ask them to come back. So really, bottom line for me is deciding if I feel the patient is too sedated to have a coherent consultation. And I think that line will be different for different doctors as to where they think that line goes.
That was brilliant, really, really interesting as well about at what point do you kind of decide that actually this really isn't working, and that was a very detailed answer. Thank you. And Dr. Daniel Corn.
Yeah, so I definitely agree and would like to sort of pick up on Pia's point about time. It's a really interesting one because I think in a face-to-face consultation, although you are managing time, there is a shared responsibility about how you manage that time and the interaction between the patient. And as we move to remote, I think there can be this sort of sense that it's a bit tick list if you do things remotely, and you kind of you do it a bit quicker. You finish a telephone conversation a bit quicker. It doesn't sort of expand to the natural, to fill the sort of natural space. And I think we just, as clinicians, have to be mindful of that. But perhaps I think there's a sense from patients that this is a speed exercise as well. So to reassure them, particularly with complexity, that we are actually taking the time. So to be clear on the question of how we ensure clinical care, I think us making sure we take time and reassuring patients that we take time, I think not being afraid to transfer it to a face-to-face consultation if you think that's safer, and to do that at an earlier point, and to be prepared and not to feel pressured that you need to pursue this line because that's how the consultation has come in and that's kind of the most efficient way to do things. I think knowing your own boundaries or limitations of what feels comfortable for you to manage remotely. I've got some colleagues that are very comfortable managing mental health remotely and responding to electronic consultations that way. That's not a preference for me personally, and it doesn't feel like I don't feel comfortable doing that. So I think knowing your own boundaries and limitations, I think being aware of missing hidden agendas. So, again, dialogue, free-flowing dialogue allows for you to pick up on cues and hidden cues, if you're face-to-face visual cues that you might want to delve in. And, a lot of our training is built around picking up those hidden cues. And we should be careful and mindful of not totally missing those because inferring stuff from text and other means is difficult. Picking up on intonations on telephone calls, again, it's slightly different to picking up on those visual cues. So, yeah, missing hidden agendas. And being aware of patients not feeling able to fully put everything down on a form, sometimes amending forms because it fits better to get through the right process, and just not being able to express themselves in a free way. So those are the things that I think, in order to assure sort of safety and good quality clinical care, that you need to those are the things that I would be mindful of. Yeah.
I do think the big red flag that I would like to come out of any message going through a digital is that, yes, it works, of course, across a load of different platforms, but complexity and digital need particular scrutiny. Individuals with comorbidities, who are the individuals who are generally, the inverse care law applies to them, those individuals rolling out digital uniformly across a practice or a network setting, saying this is the default method of communication. That is, I think, a dangerous assertion. Yes, in certain parts of the country where digital is mainstream, and Westminster bubble and so on, of course, there are huge advantages. But we need to be mindful that complexity, which is a minority presentation in the country, most practices don't deal with high-level complexity. They deal with moderate level, but the practices which do, the practices in the high IMD groups, deprivation groups, rolling out digital and saying you must exclusively use this, or this is the default model, is in itself a step back in terms of safety as well as communication.
What Carmel's saying is really interesting, and if practices, I'm presuming practices are doing this, certainly my practice isn't making, digital the first port of call, but if you are, it could actually be a quote unquote convenient way of excluding your more difficult patients so that you can get on with the nice, simple urinary tract infections. Just kind of being a bit naughty by saying that, but it comes back to my previous statement about our attitude towards these patients. And whether we have a willingness to deal with these people, if we'd rather they fell under the sofa.
And that's all we've got time for this week. My thanks to Dr. Pia Martinez, Dr. Daniel Korn, and Dr. Carmel Boyan Irvin. Thanks. Bye.